Bill Gradishar, professor of medicine at Northwestern University, where I am also chief of hematology oncology. The use of some molecular tools are becoming more and more common, not only in breast cancer, but in a variety of diseases. And a couple of tests that you may hear about are circulating tumor cells, which really reflect the fact that as a tumor grows and certainly as the volume of disease increases, there is shedding of tumor cells that can be detected in the circulation. And we've known that their presence has been prognostic for some time. And similarly, we also know that as cells die, also we can find evidence of that based on circulating tumor DNA, components of the tumor cells. So the question then becomes whether or not knowing that or quantifying that or characterizing those either cells or the circulating tumor DNA helps inform the physician about how to optimally take care of the patient. So in early stage disease, meaning patients who do not have evidence of disease in some other organ, there is no evidence at the present time that that information is helpful for making any sort of decision. But in patients with metastatic disease, as I mentioned earlier, circulating tumor cells can be prognostic, meaning that you can get a sense of what the path or trajectory of the disease may be. But it still remains not a what we would view as standard of care thing to do. On the other hand, circulating tumor DNA, which again, as I mentioned a moment ago, is evidence of the characteristics of the cancer cell, may offer the clinician some insight into certain characteristics of the tumor that you can then base treatment decisions upon. And I'll give you a couple of examples. So in patients with metastatic breast cancer who happen to be hormone receptor positive, if you knew they had a particular kind of mutation, you would partner the anti-hormone therapy with a specific targeted therapy. In the absence of that mutation, which you can detect in circulating tumor DNA, that targeted therapy would have very little benefit. Additionally, as patients with metastatic disease develop progressive disease, and they are going through many of the standard therapies we have available, the current crop of clinical trials, or many of them, look at specific abnormalities in the tumor cell, what we refer to as mutations. And we develop drugs that target those mutations. And the only way that you would know that you're eligible for such a clinical trial is by characterizing the tumor, either with tissue, which would require a biopsy, or getting a blood sample to determine whether that mutation is circulating in the blood. So again, this is an evolving area. Many of these things aren't viewed as standard of care yet, certainly in early stage disease, but they're quite commonly done at some point in patients with advanced or metastatic disease.